Thank you. Thank you for that nice introduction. So I guess when I was approached to give this talk, I had to think about a few instances or how I have actually experienced malaria before coming to the US and after coming to the US. And just one word struck me most, that malaria is actually an interesting ambush kind of disease. That's why I came up with the topic, the deadly ambusher. So if we revisit the meaning to the word ambush, I mean, you keep seeing the words lying concealed, attacks by surprise, attacking unexpectedly, attack suddenly and unexpectedly. It keeps coming up now and then. But I will step back and bring you back to the life cycle of malaria. And from here, we can see how complicated it is. We really appreciate that it's multiple stages. And within those multiple stages, it has points where it just lies in and your body cannot detect it. It takes time and while before actually you respond to it and it comes out into your system. And when it does so, it comes out with such a great bang. And this is the point that everybody who has had an experience with malaria will say that, gosh, may the world just open and take me right now, because you get so sick, fevers, chills, and your joints are not yours anymore, and you just want to go. That's it. But interestingly enough, this slide is just supposed to show us or the deadly part of it. And I think earlier talks have mentioned how the parasite can actually interact with the host molecules and find a way of sequestering or hiding the infected red blood cells within your system. So in the endothelium, it has been shown to interact with CD36, and in the placenta, it will interact with chondroitin sulfate A. And all this will enable the parasite to be in a state that your body cannot quickly respond. And when it does respond, it might over-respond, just like Dr. Mo mentioned that first pregnancy mothers tend to over-respond to the infection and leads to a lot of pathology of the placenta. And eventually, the baby might be born low birth weight, or in some cases, the baby might die. Now, if I recall, in fact, I verified this information with my mother yesterday while I was making this talk. I was actually born when she was malaria positive, and she actually fainted the day she was going to hospital to give birth to me. So I guess that was my very first experience with malaria. And good enough, you see, I've been working on placental malaria for it's almost a decade and a half. So I guess I was born in it, to work in it, and to deal with it. Well, let's keep going. So a couple of problems are very prominent with malaria. One is drug resistance, which has been there since, I think, the 80s, 90s. And my personal experience with this is, as I was growing up, going to school, of course, I went to a boarding school, but since I was born with malaria, my parasites became too resistant to chloroquine, which was the main first-line treatment in Kenya. So when I went to school, I couldn't be treated with chloroquine. So that meant I couldn't go to the school's clinic. And there had to be an agreement or arrangement between me, my parents, and the school officials that if my son gets sick, put him on the next van back home. So technically, you lose class time. You have to catch up when you come back, And my preferred drug was SPs back then, or sulfadoxine pyrimethamine-based drugs. And school could not buy it for me. So I had to go back home, spend $100, which was, I think, $1.50 way back when. But that was, I think, 2-3 days average income for people back home. So it was expensive treatment. Anyway, now there's this other medicine, which is top-notch, artemisinin, but resistance to this medicine has also been mentioned. And it's threatening and especially very bad for people like me who have left the system, and now we are no longer exposed that much, and we need medicines that can actually kill the parasite immediately, get into contact with it. I'll get to that story later. Anyhow, so the other interesting thing is people who have been born and grown up in malaria endemic areas, say like Kisumu or Mombasa, Kilifi to be precise, the children, before they reach the age of 5 or 6 years old, can sometimes present with very high parasitemia, which for an adult can kill you. So my dad used to be a chief laboratory technologist, and they used to run all this massive diagnostics on children in Kisumu and the environs. So once in a while, I mean, we wouldn't be sick, but since your father is the one running the whole thing, you guys will all be tested. Then he comes back home and says, you know what, you guys are sick. You're sick, you're sick, you're sick, you're sick. I'm like, but Dad, I went to school today, I'm fine. Then he says, okay, look at this. This is 10,000 parasites per, you're sick, we have to treat you. So anyhow, so that happens a lot. And I guess it might explain why children sometimes will just drop dead. You know, they have had this high parasitemia without knowing, then the great ambusher, the deadly ambusher unleashes its wrath on them, and you know, tomorrow your child is feverish, febrile, you admit, but the medicine is not adequate enough to treat, and your child dies. But anyhow, the mechanisms of how this happens is still a bit grayish. We don't quite understand that very well. And then the interesting thing about malaria is the more you get exposed, the better off you are, apparently. And that's true, based on my experience, because while I was back home, I mean, once I became an adult, I would hardly get sick. 3, 4 years would pass by, you know, you're fine. You get bit by mosquitoes, you're like, come on. It's all right, just want blood, take it, go. But anyway, now the problem is I have been a couple of years removed from my system or from my environment. But I've gone back home, back and forth, and unfortunately, every time I go back, whatever I do, even I sleep on the bed net, use insect repellent, use prophylactic, whatever, chloroquine, sulfadoxine. When I get back to the US, I have to be treated seriously because I get sick. Simply because I think my immune levels or my antibody levels against the parasite are so damn low right now that I can't help myself. I'm just as good as somebody who has never had an incidence of malaria. And that explains why we still need concerted efforts towards developing sterilizing immunity, which up to this moment still escapes most of our thoughts. I mean, credit to Professor Steve Hoffman is trying to do the whole sporozoid, immunization programs, but getting those sporozoids is a difficult thing. So it's good work, but a lot still needs to be done. So, measures against malaria, just like I mentioned, a couple of things have been done. Mass drug administrations, and women have been given treatment during pregnancy. Like Dr. Mo said, it works. But if it fails so bad, right? And the prophylactic treatment for travelers, I guess now I'm in that group. I have to be treated whether I like it or not. And those medicines don't taste really good, unfortunately. Yeah, and trying to reduce the vector contact with the host. So bed nets are being issued right now, insect repellents, screened doors, screened windows, residual spraying of houses with long-lasting insecticides. But unfortunately, or fortunately, the mosquito also is not just seated there doing nothing. I have lived in a house that is screened, right? But when you're sitting out there for the evening coffee or evening whatever drink you want to take, the mosquitoes will bite you. And unfortunately or fortunately, if one of you has a parasite, it will get into your system. And for me right now, if it gets into my system, I'm not that immune. There's no vaccine. I will be sick. Good enough, I know what malaria is. So the moment I start feeling funny, I'll quickly suspect that it's malaria. But for those who have never had an experience with it, you know, you might think that you're probably just tired. You know, you had a rough day, you go sleep, but unfortunately, you might end up in the ER because your liver is bursting, or your red blood cells are all gone, you're anemic, and all that kind of stuff. So still, the best measure will be vaccination. But how do we get there? slow, concerted effort, and the studies that are being done are really encouraging. But the biggest challenge right now, I mean, bearing in mind that Georgia, not so long ago, maybe like, what, was it 6 decades ago? Malaria was a problem here, I think so. Yeah, with concerted efforts, massive spraying, massive killing of mosquitoes and treating all those who are sick, malaria was eradicated here in the US, or especially in Georgia. But this map just shows us the traveling routes of the world, shipping lanes marked in blue, the red are airline travels. And you can see that right now it's very easy for somebody to get from the US to any other part of the world within 36 hours. So what if we have a stowaway, the mosquito, or a passenger who was sick with the parasites? Now this is what might happen. This map over here is just a heat map showing different types of malaria vectors and where they exist in the world. So technically we see that the vectors are almost everywhere, right? And if I go back here, definitely the travel routes almost synchronize with where the vectors are. So it is really important to keep on the good work or the hard work that we're trying to do in terms of treating the sick or eliminating the disease if possible. And of course, I travel from here, Georgia, to Kisumu, which is somewhere here, which is in blue, the hot spot. So anyhow, in conclusion, infection prevention strategies that might work or that should work should include vector clearance, vaccination campaigns. We need better drugs. We need community education. And above all this, we need poverty reduction. Just like I said before, that it will cost $1.50 to treat an individual. But that $1.50 is probably 2 days' work for some people down there. So yeah, who would want to spend $1.50 just to treat one person and you have a family of 4? So the poverty reduction is, I think, one of the greatest things to be done. Other than that, it leaves us with a big question that what can we individually do about the problem? I mean, in trying to reduce malaria prevalence, trying to ease the pain of those who are suffering from malaria, and also just trying to ensure that the children who are born at least make it to adulthood without too much problems. And just in red again, that what can we do about this? Anyhow, thank you to so many people who have been instrumental to my life with malaria, both education-wise in malaria and experience-wise in the US. So Dr. Mo, Dr. David Peterson, Dr. Demba, and thanks to the organizers of this seminar. I think it's a really good thing that we should be having almost even twice a year. Otherwise, that's all I have in terms of my perspective.
Any questions for Simon?
Yes, Eldon.
You forgot to mention how we always like when you come back with malaria because you like to put you right in the needle. It's hard to get fresh blood.
Absolutely. So yeah.
Recording that, right?
No. Yes, Judy.
Simon, how many times have you had malaria?
Okay. When I was in elementary school, I was sick almost once every month. But when I went to high school, I was sick at least twice every term. A term used to be 3 months. So anyway, I used to call that half term because I would be sick right in the middle of the term when everybody is stressed out and I'm like, bye, I'm going home. Yeah, so it's a number of times. And since I've been here, I think I've gone home, it's been, what, 7 years? I've gone home about 14 times. And out of those 14 times, I think 10 times I've been sick.
Do
you take prophylaxis when you go back home, and what do you take?
I usually take artemisinin-based drugs before I leave the U.S., and when I get home, I take more drugs, and when I come here, I take more drugs.
No, like the prophylaxis, like Malaria.
No. 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 I just go straight to treatment. I don't want to take chances.
Maybe what taking the prophylaxis?
Well, no. One time I took, what was it? I've never had very good luck with, was it mefloquine or whatever? The one that makes you go bananas. Yeah. Yeah. They're not fun.
So what does your mom think we should do?
In terms of,
Malaria. So what do people, who haven't left, who are there all the time, what do they think would be the most helpful thing for them?
prevention. Now that, okay, I didn't say it, but my mom is or was a nurse before she retired. So nurses are like, prevent, prevent, prevent. So that's how we used to sleep under bed nets, but bed nets are too hot for Kisumu. So you might be tempted just to, pull it over and, yeah. But prevention is whatever they are preaching right now.
So when you are sick and then you go to the hospital, and before they give you the drug, do they do diagnostic?
Yes, they do diagnostic. But the good thing with, or should I say good or bad, is most of the people, especially in Kisumu, are very adept at self-diagnosis. You know it when you have it. So you quickly go, because you don't want to wait. The hospital might be 12 hours away. If you wait within those 12 hours, you might not be able to walk. So your best bet is take the medicine that you have, tomorrow travel to the hospital and tell the doctor that, yes, I have swallowed chloroquine or I've swallowed, what was it called? Fansida or something like that. Yep.
Last question.
What's your experience been as a father? Have your kids been sick as often as you when you were little?
Luckily enough, my kids have never had a story that they've been sick from malaria, but I guess it's because their mother is a doctor. So they've got to smear all these bad-smelling, what do you call them, and insect repellents, petroleum jelly before they sleep, and all that kind of stuff. And maybe genetically they inherited something from me.
All right, let's
Yep.
thank Simon.
Thank you.